Thank you very much. Good afternoon, good evening to all participants of this important meeting of the Asia Pacific Liver Disease Foundation. I am Mukta Sharma. I work for the World Health Organization in their Southeast Asia regional office. And I've been asked to speak on a little bit about what are the WHO targets for elimination and what has been the progress on elimination targets in our region, in Asia, but also globally. A quick outline of my presentation. I'm going to say a few words by way of introduction to the concept of elimination, what the global and the regional situation is. I'll say a little bit about what does it entail when we say elimination and a hepatitis-free future. What does that actually mean? I'll say some words about opportunities and gaps, and then I'll summarize and say what the way forward might look like. You may all have heard of the Global Health Sector Strategy on Viral Hepatitis. This was set up in 2016 as a 5-year plan, and this really followed a very clear outline in the SDG 3.3, looking at controlling and eliminating hepatitis as a public health problem by 2030. In terms of deaths, what that means is that they are looking for a 65% reduction overall in mortality between the baseline of 2015 and 2030. And in terms of new infections incidence, the target is a 90% decline in new infections between 2015 as a baseline and 2030. There is a sort of target in 2020 for mortality as well as incidence, and that is 10% reduction in mortality in 2020 and a 30% reduction in incidence in 2030. Now, just to say, where were we at baseline? And are we expecting that things have really moved on? And these, if you look at the interventions, on the left-hand corner, you have vaccination, you have prevention of mother-to-child transmission of hepatitis B, you have blood safety, you have injection safety, harm reduction, particularly for people who inject drugs, diagnosis and treatment of Hep B, as well as diagnosis and treatment of Hep C. And you can really see that there's quite a lot of progress on the first four interventions, sorry. But if you look at the other 5, testing and treatment, as well as harm reduction, then of course we're starting from a very low baseline and there is a long way to go. There are no new data at the moment to give us an update on these indicators globally for 2020. We are in the process of collecting data and analyzing and reporting data at the World Health Organization. Countries have reported to us. And we should be able to, in the next few months, give to the world some sort of snapshot of where we are in terms of overall progress in these 5 indicators. Just to say a little bit about what are the targets, and you can see that the 5 key interventions are again listed under in the first column. And if you look at 2015, that shows you the baseline. And if you go to 2020, as well as 2030, what the global targets are. What's notable is harm reduction has a target of 300 new needles and syringes given to each injecting drug user per year. At the moment in 2015, our baseline was 27. This is supposed to go up to 200 in 2020. There's really a very large gap there. And you can see that for testing and treatment, again, we are not doing very well because you are seeing that despite very, very cheap drugs, despite very, very cheap testing available in many settings, there is no access for many people for treatment. So what does the global strategy for elimination entail? As you can see, there is no clear indicators that have been agreed globally to say this is what a country should be doing in order to have the certification of the validation of its elimination. And these are the options that are being discussed within the World Health Organization. They are being looked at and discussed in terms of impact monitoring, in terms of service delivery coverage, in terms of how the programs are delivered. What are the equity and human rights issues in terms of how these programs should be delivered? Is stigma addressed? And in the way that we are working, are these gains sustainable? We are expecting to have some clear tools for this available in 2020. There has been some disruption around, a clear clear set of indicators that have been agreed by everybody. And these delays are also happening because of, COVID and the focus on COVID. Many people are completely focused on that at the moment. And what that means is that hepatitis ends up being a lower priority in the mindsets of many people. Having said that, there is going to be a pilot testing protocol available for the last quarter of this year. And there are countries that are very, very keen to have the piloting of the validation protocol. I'm thinking of countries like Egypt that have really made remarkable progress in this area. Some of the issues around elimination and what that means have been researched, and there is data now to show that simplifying service delivery, having different models of service delivery, having micro-elimination plans, and very, very clear ways in which to address hard-to-reach populations will in fact contribute to a large progress that can be made in the elimination work that countries are doing. Elimination cannot work if it is targeted at no one. Elimination has to be targeted at the most difficult to reach populations, as well as the easiest to reach populations are both important areas that need to be considered in any elimination strategy. What is very clear is that treating hepatitis till now has been seen as something that only hepatologists did. In many countries, it's not clear whether hepatologists or infectious disease physicians should be treating it. And there is clear evidence now to suggest that when you take hepatitis treatment out and you decentralize it in one-stop shops, as well as treatment in the community for injecting drug users, there is clear efficacy, there is clear possibility of taking hepatitis treatment outside of provincial as well as regional level treatment centers. This can be taken down to the level of a primary healthcare center with an MBBS doctor in some settings. In some settings, it will require a little bit more sophistication. Now, people say, oh, it's not possible to really eliminate hepatitis C. But we have seen one country, Egypt, that has a massive burden of hepatitis C. 4 to 5% of the general population was living with hepatitis C, is living with hepatitis C, and this was due to iatrogenic transmission. But look at the achievements in Egypt. And this is a story which can inspire all of us in all countries in our region. Between 2014 and 2018, Egypt, which happens to be a middle-income country with conflict, treated 2.4 million people. And the vast majority of those people were in fact treated by the state. Out-of-pocket expenditure was very limited, and you can see that the government has really taken very, very clear ownership of the program and did some market shaping as well as massive work around access to drugs as well as diagnostics at an affordable level, and has been able to put 2.4 million people on treatment. So if Egypt can do it, India can do it, Bangladesh can do it, Thailand can do it, Myanmar can do it, China can do it. A little bit about the region now. Where are we in the region? This data is data which is informal data that we have collected in the regional office, bringing together people from the programs. And we have some estimates of what is the prevalence of hepatitis B. And if we say that about 20% of these people need treatment, may have a high viral load, then out of those currently, only 9% are diagnosed and 4% have been put on treatment. For hepatitis C, similarly, if the 2017 estimates are saying that we have about 10.3 million people living with hepatitis, only about 8% of those are diagnosed. Out of those, 20% have been initiated on treatment, and about 89 to 90% have been cured. Overall, what this is showing is a clear picture that the programs are still nascent. The supply for treatment, as well as testing, as well as the demand for treatment, as well as testing, both need to go a long way. So what are some of the opportunities? What can we be doing so that when the conference happens in 2 years from now, these numbers are certainly much higher? The first is just to remember the opportunity of prevention remains with us. The opportunity of effective vaccination, of hepatitis birth dose coverage, as well as preventing mother-to-child transmission and injecting safety are very clear opportunities that we should be using to the best of our ability. WHO tomorrow is going to present its guidelines for prevention of mother-to-child transmission using antiretrovirals. I'm not going to speak about that, but that is a clear opportunity with very, very cheap drugs which are available to all of us to use. Harm reduction is another area of work where we have the opportunity to give people opioid substitution therapy, sterile injecting equipment. Injecting equipment is cheap. Opioid substitution therapy is also very cheap, and we should be able to use that as part of a comprehensive care and treatment package for people who are most at risk. In terms of diagnosis, we know that there are newer and simpler diagnostics out there. There are high throughput as well as point of care diagnostics available, as well as multi-disease platforms for testing. We have the Cepheid platform, which can be used for TB, for HIV, for hepatitis. And we have seen as a region the massive scale up of testing for COVID using RT-PCR, RNA testing, using the closed platforms, including the Cepheid platform. If we can scale up testing for COVID at the scale at which we've done it, we can also do it for hepatitis. These instruments will remain in the region, and they should be used to test and diagnose people and put them on treatment. A little bit about what is happening with hepatitis C. You all know that cure is possible now for the vast majority of people between 12 and 24 weeks. And the cost effectiveness of front-loading this in terms of preventing and managing sequelae has been established again and again. WHO has a calculator available, the Hep C calculator, as well as the hepatitis B calculator. I am not aware of a single country where treatment is not cost effective. Costs are also coming down. And I want to show you this graph to show you how much costs have come down. You can see that in the last 5 years, there has been a massive drop in costs. And in programs like the Indian program, the cost is actually lower than $40. A little bit about the major gaps. What are some of the challenges that we need to keep remembering as we go through this fight to eliminate hepatitis? The first is just to recognize always that this is a relatively new program. It's got limited funding, it's got limited staffing. In many countries, there's no clear home for the hepatitis program. Sometimes it sits with the HIV program, sometimes it sits with people who are focusing on vaccination, but there has to be clarity on how the hepatitis program is integrated into the universal health care program. There is no option here for a parallel program, but there is an option for a focused program within a universal healthcare context. The other clear challenge is really around data. We do not know where to focus our energy. We do not know always who to test. And this lack of strategic information, who, when, where, how, is something that the programs really need to to find a way of moving beyond. There has to be investment in data through surveillance and information systems, and it does not have to be a separate platform. There are many platforms already that exist. There is the DHIS 2 platform, which can be very helpful, and there are existing ways in which we can have real-time information recorded and reported, as we have done for tuberculosis, as we've done for HIV, as we do for malaria. These can be extended to hepatitis. The price reduction, even though there is a lot of generic drugs available in our region, we still hear of countries who say we are paying $300, we are paying $400 for hepatitis C drugs. There are challenges around how small countries with low volumes can actually access drugs. You look at a country like Sri Lanka, you look at a country like Bhutan, you look at a country like Timor-Leste. These are not large volumes. And there has to be ways of making sure that there can be pooled procurement and that the price reductions that are available to countries like India can actually be available to all countries in our region. The main issue around demand generation as well as supply that is still being raised again and again by key populations as well as service providers is that of stigma and discrimination. Perhaps we have not been able to show to the people who are living with hepatitis that there is empathy in the system for them. There are many doctors, there are many airline staff who have lost jobs, who are not allowed to actually get on training programs because of their hepatitis B status. And there has to be clear protection within the law that hepatitis B, hepatitis C, once you are under treatment, as long as your viral load is suppressed, as long as you're cured, you should not be discriminated against. Those legal protections are missing. There is also a lack of awareness in all populations, and this is compounded by asymptomatic acute infection. People do not know that they are sick. And there are no routine ways for people to check on their hepatitis B and hepatitis C statuses at the moment, because we haven't been able to even to focus on the high-risk populations. It's not clear how we can do this in the general population in many countries in our region. Finally, and most importantly, resource allocation. Resource allocation is yet to catch up with the disease burden. And I do want to remind all of us that the disease burden for hepatitis exceeds that of HIV, TB, and malaria combined. So what are the ways forward? What can we do? It's clear that elimination progress is still small and uneven. And I've just listed multiple challenges, underutilized opportunities for you. Every country has to believe that there is an investment case for ending hepatitis B as well as C. Countries need to have a national costed action plan, which is going to list out where they'll be able to focus, what they will do in the short term, what they will do in the medium to long term, and how those resources will be raised. A key issue is, how do we prevent the patients having to pay out-of-pocket costs for this? The recent price reductions have to be leveraged. We cannot allow the middleman in most of these countries to be making money and governments having to pay much more than they need to for people to get access to treatment. We must follow the evidence and we must prioritize key populations, and we have to find a way of addressing stigma and stigma reduction. There are many opportunities to do that. We can learn from the work that has been done in tuberculosis, the work that has been done in HIV, the work that has been done in leprosy and mental health. Hepatitis is not the only disease where there is issues around stigma and discrimination. Stigma and discrimination is a health system issue. All of our health systems must, within their governance, consider this issue. Finally, advocacy for international funding needs to happen constantly, but domestic resources is where we are going to find the majority of that financing. And financing innovation is critical to doing this. I'd like to stop here, and I'd like to thank all of you for your attention.